is from Richard Whitehouse. Richard, for those who've been to the Malvern Foot Conference before, will know Richard very well. He's an excellent speaker on radiology. Every time he speaks, I learn many new things. He's a consultant in musculoskeletal radiology at Manchester Royal Infirmary, retired in 2015, but not fully retired, so he's still working part-time. He's a past president of the British Society of Skeletal Radiology and a member of the European Society of Skeletal Radiology. Richard, welcome, and we look forward to hearing from you.
Thank you very much. I can't tell you what a pleasure it is to be stood before a real audience. I feel I could reach out and touch you, but I'm not allowed to. The place of the plain radiograph, well, that should obviously be firmly in the hands of an interested radiologist. But it isn't. Reporting radiographers probably report more plain films of the foot than radiologists do nowadays. And I would think an orthopedic surgeon with a foot interest will have considerably more experience and interest in foot radiographs than the average radiologist. So it's what is the role of the plain radiograph in the diabetic foot in 2021. And of course, it's the same as it's always been. It's an aid to diagnosis and it's an aid to management and follow-up. But you have to make it work for you. And I think you should start by letting the radiologist know everything that you can let him know about the patient on the request form. And there's very little space to do this in. A colleague of mine in Bolton has a pro forma. He won't allow a diabetic foot radiograph to be performed unless his pro forma is completed. So I have seen medico-legal cases where the radiologist is unaware that the patient is diabetic. You need to know if the foot's neuropathic. In my practice, every foot radiograph that comes from the diabetic service is both neuropathic and usually ulcerated, so I hardly need answers to those questions. But if there is an ulcer, it's nice to know where, it's nice to know if it looks clinically infected and whether or not it probes to bone. I'd like to know if the foot is warm, and if it is, what the temperature difference is from the other side. And is the foot swollen? Now, I can see that on the radiograph, but an awful lot of my colleagues don't even look for that feature. And what is the clinical suspicion? That helps considerably. And of course, all the studies of radiographs are comparing them with MR, and the radiologist is blinded to all of this information. What's new? Well, nothing really is new under the sun. But radiology in the UK moved from film to electronic images well over a decade ago now. And since then, the image acquisition system has changed from computerized radiography, which has an intermediate reading step, to direct digital radiography, where the image goes straight to the computer from the imaging sensor. And this has considerable benefits, but that transition has not yet completed. And so there was a period where the resolution of film, 8 to 12 line pairs per millimetre, dropped to that of computerized radiography, which was barely half as good, before it came back up and exceeded that resolution with direct digital radiography. At the same time, the ability of the imaging system to cope with widely varying X-ray levels, from very thick tissues where very little X-ray gets through to the air where the lot hit the imaging plane, has increased massively. It's almost impossible to overexpose an electronic radiograph. You overexpose the patient to the radiation, but the image can still be looked at on the computer, whereas an overexposed film is just black. So direct digital radiography has a lower radiation dose per image even than computerized radiography, but a higher spatial resolution and a wider latitude. The images are just perfect. They have never been so good. So why is it that the radiograph is the poor cousin in imaging? And I think that that's a perception rather than a reality. And it comes about because there was a period, as I've said, that's still ongoing, where radiographs were of poorer resolution than conventional film. And while CR and DDR coexist, follow-up radiography may be on different systems, and the image quality goes up and down accordingly. So when you look at papers like this from 2012, I'm not saying this is true for this particular paper, but it's an item of relevance in that period. They said that, go back to the beginning somehow. They said that plain radiography has lower sensitivity and specificity than MR and nuclear medicine, and therefore is only used for the evaluation of major structural changes. I don't believe that. They said that MRI is the best modality for the evaluation of soft tissue and bone marrow changes associated with a diabetic foot. I agree with that, but does it take us very much further forward? They say bone marrow edema as the early finding of neuroarthropathy and osteomyelitis can be detected using MRI with high sensitivity and specificity, but they quote 40% for a specificity there at one end of the spectrum. So you can do really badly with MR, and actually it's very difficult to tell what bone marrow edema is due to. You can see that it's there, is the reality. It does have high soft tissue contrast and multiplanar imaging capability, MR does, and they are very useful. But the differentiation of osteomyelitis from neuroarthropathy and reactive bone marrow edema and a sterile joint effusion from an infected joint effusion, actually that isn't so simple. And from a paper that I will cite subsequently, they said this, the pattern of marrow edema can be used to distinguish reactive change from infection. But at the end of this slide, they point out that it's the importance of morphological features that makes that distinction, not the presence or absence of marrow edema per se. And that introduces an undesirable subjective element. Another paper comparing a lot of different studies came up with this table of sensitivities and specificities. And yet again, plain radiography is at the bottom for sensitivity. Up near the next up is exposed bone or probe to bone. But note the specificity for that test is 0.91. Yet they conclude that probe to bone is moderately predictive of osteomyelitis. If it's a positive test, it is the best predictor of osteomyelitis of all these tests. So, I also want to point out that we all know that if you radiograph the foot repeatedly, eventually the diagnosis that should have been made earlier will become apparent. Therefore, a late radiograph has an almost 100% sensitivity and specificity for all the conditions you get in the diabetic foot that are radiologically detectable. And so, like all good comedy, it's a matter of timing. This is the paper. Is there even a role for imaging in the management of patients with the diabetic foot is the question they pose, and I think you should all study this paper because it has a lot of important information in it. And they point out that most studies comparing different imaging modalities have a high pre-test probability of osteomyelitis because of the way the study was set up. And you then significantly affect the diagnostic effect of imaging. And you get positive and negative predictive values with really high figures, particularly for MR, and you should be skeptical of that. They point out that with a 50% pretest probability of disease and a published sensitivity and specificity of MRI, you'd get a positive probability of osteomyelitis up to 84%. But if you have a more general population of patients, only 10% of whom have osteomyelitis, a positive MRI then only has a probability of disease of 36%, a result not good enough for decision making. Of course, the plain radiograph suffers from the same consequence, but in general, the literature emphasizes the value of MRI and degrades the value of plain radiography without allowing for the repeated nature of plain radiographs against the one-off MR scan and this influence of prior probability. Then there's this paper which points out that if you combine the clinical test of probe to bone with the radiograph, you end up with sensitivities and specificities that outperform MR scanning, at least in settings where there is a high prevalence of osteomyelitis, which is the setting I work in. So, the point I'm emphasizing really is radiographs are of value, but you must repeat them, and you must repeat them endlessly at close enough intervals to influence management before changes become irreversible. And again, this same publication concludes that serial radiographs can be very persuasive, but they also point out that there is no formal evaluation of the role of serial radiographs in the literature. And as far as I'm aware, there still isn't. It's a study that if I was still in full-time practice, I might contemplate undertaking. And it's not just for osteomyelitis. Here's a patient who hobbled into A&E. It didn't hurt very much, their ankle, because they were neuropathic, but they'd gone over on it and it was swollen. And the radiograph looked otherwise normal. They came back a week later, which was good because they were re-radiographed. And the radiograph still showed no bone or joint abnormality, but the ankle is still swollen. So by my rules, that hasn't settled down. Another radiograph is required, or an MR scan, admittedly. But no, they were discharged because the radiograph looked unchanged, and they came back 2 months later with an ankle that is dislocated, fractured, fragmented, and then they get an MR scan, which played no role in diagnosis or management, but might have been valuable 2 months earlier. So serial radiographs must be repeated ad infinitum at 1 to 2 week intervals until you have a clear diagnosis or the condition that caused you to radiograph in the first place has completely resolved. I'm going to teach you how to be a radiologist now in the remaining few minutes. Should be long enough. It's a commonly held view. Can we have the lights down, please? Radiologists love to work in the dark. It seems to be the standard for us, so I don't see why it should be any different for you guys. These are the bones of the foot, missing a few tiny ones, and they go together a bit like this. The toes come together, and then the metatarsals come together, then the cuboid goes in, then the lateral cuneiform, intermediate cuneiform, medial cuneiform, big toe, navicular, calcaneum, talus. Now, in lockdown, I've done a lot of jigsaws. I have to say, that is the easiest one. And then you can stick a made-up leg onto that, and then you can underexpose it or overexpose it, and then you can digitally process it, and then you can enhance it. And those latter steps are only available for a computerized or a digital radiograph. So plain film, you either overexpose it to get the hindfoot or you underexpose it to get the toes. CR does considerably better. DDR gives you the whole lot on one image. Of course, the resolution of those images is so good that it overwhelms the imaging capability of the monitor that you look at the image on, even if it is a radiologist's high-resolution PACS monitor in the radiology department. You have to magnify these images to see what is there to be seen. And that is a step that even most radiologists fail to undertake. And the next problem we have is with electronic requesting. You will find you can request ankles, heels, feet, and even forefeet, but you cannot electronically request toes, sesamoids, or additional oblique views. In a lot of the systems that are commercially available, you have to write that into the clinical information, and then you have to hope that the radiographer, the person doing the examination, reads that and does those additional views. So you need to train your radiographers to do these views without having to be asked for them. And I think any diabetic foot ulcer must have a view that is tangential to the ulcer, because the osteomyelitis, if present, will be in the floor of the ulcer, almost invariably. And if you don't get a tangential view of the ulcer, you don't see the bone in the tangential view that will show you the focal demineralization if you use DDR and you magnify the image sufficiently. So here are a few of these odd views. This is the axial calcaneal view. The X-ray beam comes down from the back, so you get a view that looks like that. Here's the sesamoid view, the patient prone with their toes on the imaging plate. The X-rays come down from the back, and you get a view like that. Look how beautifully you see the sesamoids and the undersurface of all the metatarsal heads. So any ulcer under that part of the foot requires this view. We managed to get our radiographers to do them in 1 in 5 of the patients that need them, which is better than most places manage. Lateral toe views. Admittedly, diabetic chiarthropathy means you may not get them to flex their toes like that and get all the lateral toes on one image, but a little bit of struggling by the radiographer, they can usually get you a lateral toe view, which shows the tip of the terminal phalanx better than any other view. We went to using direct digital radiograph, dental radiographs that fit between the toes, because then at least some of the toes are behind the plate and don't obscure the image, and the image resolution is fantastic. But we lost our dental imaging unit a few years ago, and we're only just getting back up to that kind of image resolution with full-size DDR imaging. So use DDR if possible, get dedicated views, use serial radiography. If you do all that, you'll do better than the publications suggest for plain film. A little bit on how to review a foot radiograph. This is for the budding radiologists amongst you. I've heard one speaker say that they look at them. Look first at what most people forget to look at all or will miss, and that isn't the obvious thing. So look first at the soft tissues, otherwise you will forget all about them. Look at all of the bones right out to the edge of the film. Look at all of the joints for alignment and joint space. Look for foreign bodies, and look at all the previous examinations. That is the step that most people forget. If it hasn't changed in 2 years, it probably isn't acute osteomyelitis, it's just re-ulcerated. Look at the soft tissues here. There's gas in them under the midfoot, not just swollen soft tissues. So there must be a big cavity or a big open ulcer there. Look for all these pathologies. These are the ones you're likely to find if they've got as far as having a radiograph. Fractures, soft tissue swelling, neuropathic changes, ischemia, necrosis, and osteomyelitis. And usually patients at this stage have at least 2 of the above. And don't forget, particularly if the patients come from A&E, a referral source for the radiograph that hasn't been mentioned in the previous speaker's talks, be interested to hear what their steps are for managing this, that the clinical features will mislead the inexperienced A&E officer because the pain isn't localized because they're neuropathic. So you have to look radiologically for every possible pathology in every possible site, not just be led by what the request form says, which is usually query soft tissue infection. So look for fractures. Here are some odd ones that you will find are almost pathognomonic of diabetic. This weird slide of the posterior calcaneum as the Achilles pulls it off. There's another one. There's the same one on CT and MR, added nothing. There's another one where it's just avulsion of the Achilles tendon insertion, getting more and more ossified as time passes. Then there's these weird beak fractures, again, also almost pathognomonic of a diabetic heel. Almost always has an overlying ulcer and focal osteomyelitis, probably weakening the posterior cortex and predisposing to this beak fracture. You can see the one on the right is an open fracture because there's air inside it. Navicular fracture, I've shown these before. This sagittal plane mid-body navicular fracture is usually only seen in athletes. It's a stress fracture of athletes. I've seen several in diabetic feet. Here's an extremely subtle one on the left, which progressed to collapse of the the lateral part of the navicular. Here's another one that's already collapsed. You might say, which came first, the osteonecrosis or the fracture, and that's moot, I think. Here's the very subtle one. If you look carefully, there's a lucency going across the navicular with no collapse of the bone, so I think that's a fracture first. And here's one in a collapsed navicular, which is probably osteonecrotic. And there's another one that progressed to midfoot Charcot-neuroarthropathy, which this sort of fracture is very prone to in the diabetic. And here's a paper from 2014 where they identified that the navicular is reduced AP dimensions in diabetics compared to normals matched for age, sex, weight and smoking history, but only by about 1 millimeter. So they didn't have any cases where it had collapsed right down after fracture. But don't forget, the Americans call the scaphoid the carpal navicular, and the scaphoid gets osteonecrosis of its proximal pole after a waist fracture. The navicular might be at a similar risk. So I think it is definitely multifactorial, but fracture should be included in that list of possible causes. The Jones fracture is also most commonly a stress fracture in athletes, but also we've seen several of these in diabetic patients. Jones fractures are fifth metatarsal fractures, not right at the base, but somewhere down the shaft in those different zones. And here are several of them. I'm not going to waste time going to them all individually. There's a healed one. There's one that appeared over 6 weeks. And I think that maybe the combination of neuropathy making it painless to exercise, abnormal bone in the first place, and exercise that you might encourage all your patients to undertake may predispose diabetic patients to stress fractures that we usually, but albeit uncommonly even then, see in athletes. There's a hypothesis worth testing, I think. Another paper for somebody. Ischemic toes, easy on the photograph. We have a PACS service, a clinical photography service that puts their images onto our PACS, so I can see the image of the clinical photograph at the same time as reporting the radiograph. And I think that's as close as I want to get to some of these feet, but is also extremely helpful. And if you look carefully, you can see that the radiographic corollary of a necrotic toe is loss of the soft tissue thickness over the tip of the third toe compared to the other toes, but no change in the appearance of the underlying bone. And that's important. Dead bone doesn't dissolve away if it gets infected. It's dead. The cells that dissolve it away are also dead. It's the viable bone next to the dead bone that gets osteomyelitis in it radiographically. I'll just emphasise that. So here's one, another necrotic big toe. It's got gas in it, this big toe on the middle radiograph that you see there, which is another feature sometimes of necrosis rather than infection. That was amputated, but the osteomyelitis developed not in the amputation site, but in the toe next door. All this severe osteopenia in the toe next door. And here's another one, fifth toe amputated. The osteomyelitis then develops in the metatarsal head of the fourth toe. So don't forget to look at the toe next door for sideways spread of osteomyelitis in the amputated foot. Bit on Charcot-neuroarthropathy classifications. I'm emphasising only stage 0, which was added to this classification later because the radiograph is described as normal, but it's normal bones and joints, not normal soft tissues. They're almost invariably swollen. So soft tissue swelling on a radiograph of a diabetic foot is a red flag, not something to be dismissed as cellulitis. I'm not going through all the other eponymous classification systems for this condition because I don't use them. And I was asked in a lecture once, how do you diagnose radiographically Charcot foot? And I say, well, you don't. You get the clinician to think of it first, to radiograph the foot and offload it, and then worry about confirming the diagnosis. And if you can do that on the radiograph, you're home and dry. If you need an MR scan, get one. Here's an example. This is already radiographically abnormal. If you look on the DP view, the one on your left, the gap between the first and second metatarsal bases is widened, and there's soft tissue swelling on the medial side of the adjacent part of the foot. So that is abnormal, and it's highly suggestive of an just about acute, bordering on subacute midfoot Charcot-neuroarthropathy, which we did confirm with an MR scan, and which was offloaded and serially radiographed for follow-up for 5 years, and it's still progressed. So that maybe answers the question set to the next lecturer that we're getting on how long do you offload for. 5 years wasn't long enough. I've told you this already, but the radiologist needs to know the prior probability of what's wrong with the patient. If the foot is warm and swollen but not ulcerated, Charcot has to be top of the list of important diagnoses not to miss. May not be common compared to the things I've listed below there, but it's the most important. Fracture comes second. If you have an ulcer that probes to bone, osteomyelitis is top of the list of the things you need to look for. But you still have to look for everything else. I'm going to whip through septic arthritis quickly. I think it's underemphasized in the diabetic foot, but it's extremely common. And joint space narrowing is the radiographic hallmark, but by the time you see that, it's far too late. So that's a place for the MR scan, with the caveat that you can't tell whether the effusion is infected or not. So this is the same paper again, and they point out, again, going back to what I said at the very beginning, if you're going to treat a soft tissue infection for several weeks with antibiotics, you have time to wait and see if the radiograph is changing and they've got underlying osteomyelitis or not. And then you don't need an MR scan because your treatment won't be changed. But again, they point out they don't have any seroradiographic studies that confirm that in the literature. There's a progressing osteomyelitis, loss of the terminal phalanx, demineralization of the middle phalanx despite treatment. Here's one. If you look carefully, you'll see the bone is demineralized in the terminal phalanx of the big toe in the middle image, but that bone is reappearing on the right-hand image, and that's a response to effective treatment with antibiotics. And here's another one that does the same thing in the second toe. The bone is demineralized, not destroyed, and when it effectively responds, the bone comes back again, as you see on that third image. I don't think the lights have been dropped effectively, but that would show if they were. That's another example of the same thing. I'm going to move on. There's a gross example in the midfoot, demineralization around the 4th and 5th tarsometatarsal joints from infection. An MR scan told us nothing more because the patient couldn't keep still. And it did remineralize, albeit with bony irregularity, on effective treatment. Another one showing the same thing. So, sclerotic bone is dead, you need to remove it. Demineralized bone is viable and may return on effective antibiotic therapy. Couple of pitfalls: fracture dislocation, infection, neuropathy may all present as non-specific swelling on the dorsum of the foot, particularly to an inexperienced A&E officer. So the message should be that if you radiograph it, repeat that and repeat that again until you have a diagnosis or things have resolved completely. And the same message again: fracture dislocation, infection, neuropathy may all pass unrecognised on the first radiograph, even if it's been reported. And I hold my hand up to this. One of the worst things a radiologist can have is the air of infallibility. Okay? Give us a second chance. Repeat the radiograph after an interval and we might spot what we missed on the first one before it's too late. So get the most from your radiology department and your radiologist. Don't keep us in the dark. And clinical suspicion and serial plain radiography should remain the mainstays of diagnosis and management of the diabetic foot. The MR scan should be performed after the case has been discussed with an appropriate radiologist or in an MDT, or where surgery is contemplated, because it does help you decide what level amputation should be performed at. And it's an adjunct to, not a replacement for, the radiographs. You need a dedicated team of radiographers that will perform these additional views. It would be nice if they removed and replaced dressings and casts, but we've never managed to get them to do that. They should use DDR for everything. They should do tangential views whenever they're needed. And you should use a clinical photography service that gives the images to the PACS system so the radiologist can see them. Thank you for your attention.